So now that you're familiar with the case, let's take a closer look. So the Paris system, which is a standardized universal system, is used for reporting urine cytology. Its focus is for detecting high-grade urothelial cell carcinoma, and it uses key features such as nucleocytoplasmic ratio, chromatin quality, hyperchromasia, coarsely clumped chromatin, and membrane irregularities to classify the specimen into 5 distinct categories. And for each category, there are clear guidelines with regards to follow-up and management of the cases. The first category is non-diagnostic or unsatisfactory. Either the urine is low in quantity or low in quality. The next category is negative for high-grade urothelial carcinoma. The rate of malignancy in this category is up to 10%, and follow-up guidelines are managed as clinically indicated. So the patient may not need any follow-up, or if there's any clinical indication, it will be decided at the GP's discretion. The next category is atypical urothelial cells. The rate of malignancy in this category is 8 to 35%, and the follow-up guidelines are to repeat the urine sample, or if there's a high clinical suspicion for malignancy, refer to cystoscopy. The next category is suspicious for high-grade urothelial carcinoma. Rate of malignancy in this category is 50 to 90%, and the follow-up guidelines are referred to specialists for cystoscopy. And the final category is high-grade urothelial carcinoma, risk of malignancy being more than 90%, and follow-up being referral for cystoscopy. So urine cytology has a very high specificity for diagnosing high-grade urothelial carcinoma, and therefore the false positive results are very low, less than 5%. But it has a very low sensitivity for detecting cancer, in particular detecting low-grade cancer, with the sensitivity for detecting low-grade cancer being as low as 10 to 30% based on some research, and an overall false negative rate of up to 60%. Conditions associated with false positive results are infections such as polyomavirus, cytomegalovirus, even stones, urinary stones, instrumentation such as previous cystoscopy, catheterization, chemotherapy, radiotherapy. All of these conditions can result in cellular changes that can mimic cancer and lead to a false positive result. The false negative results can be numerous. One is due to the sample quality, if the sample was not sufficient in numbers or preservation. And the other is for conditions such as low-grade cancers, in which the cells closely resemble normal urothelial cells and they can be missed. And also low-grade malignancies don't shed regularly into the urine. Also, some malignancies shed in waves, and therefore on that particular urine sample, they may not have actually shed any cells into the urine, which would lead to a false negative result. The other modalities we can use to enhance diagnostic accuracy, especially for borderline cases or for low-grade disease, and to address the high-grade focus of the Paris system, include FISH testing, such as that used in Eurovision, molecular testing, and immunocytology. These tests, whilst being very sensitive, however, have a low specificity, and we can get abnormal results in other conditions such as infections, inflammation, cases where there's been instrumentation. And also, they are costly, and the costs are commonly not covered by Medicare. So all of these things have to be taken into consideration when ordering these tests. This case highlights the evaluation of macroscopic hematuria, including the use of urine cytology, the Paris system for reporting, and follow-up recommendations for each category. It also underscores how false positives and false negatives can occur, and how ancillary studies such as FISH, immunocytology, and molecular markers can improve diagnostic accuracy. Remember that careful adherence to established guidelines ensures high-grade tumors are detected promptly, low-grade tumors are monitored appropriately, and patients receive evidence-based follow-up tailored to their risk. Thanks for watching.